Innovation, imagination, wonder. These are just some of the words used to describe Dr. Harvey Passes. Dr. Passes explores interesting people and ideas that will stimulate you. He questions the people who develop, create, and employ novel concepts in business and everyday lives. He especially loves to speak with successful people. How did they do it? How can you do it too? So let's join Dr. Harvey Passes in his quest of wonder and curiosity as we watch Dr. Harvey Passes present.
We're going to discuss something today that I see, I can't say every day, but I see it most times during the week. And it's something that's troubling. It's something that I see in my office as a dentist, and it poses a perplexing problem. And that problem is seeing usually a young girl who comes into the office, she opens up her mouth, and I see areas of tooth structure that look like they've been worn down with acid. And you see the telltale signs of a very interesting kind of decay. This decay is seen just in a few certain circumstances. And one of them is something that affects a number of people. Maybe you know someone who is afflicted by this, and we'll discuss this today. And the topic I'm discussing is bulimia. We're also going to get to anorexia, nervosa, anorexia or anorexia? Anorexia, nervosa as well. And well, we're going to get into what that is, but believe me, it's far more common than you know what it is. And this individual who I'm speaking to off camera here, who will now become on camera, is an expert in the field. So I'd like you to welcome Dr. Maryann Schaefer. Dr. Schaefer.
Good to be here, Dr.
Oh, it's great to have you here, and I know you're such a busy person, and I appreciate you taking the time from your business just to come down here and help me to inform everyone else on what we're going to be talking about. Let me tell the folks at home a little bit about who you are, so they can appreciate you as much as I do. Dr. Schaefer is a licensed mental health counselor, and she got her PhD from St. John's University right down the road in Jamaica here. And she's been counseling in psychology for years and years and years. I think you've been in private practice for about more than 25 years in Manhasset. And you're also a former professor at Adelphi University as well. So you've got some good credentials, and you've been around the block a little bit. Let's get right down to this.
Sure.
This is an area that I know is near and dear to your heart, and you see a lot of people with this problem. What are we talking about? Is this something that what is anorexia, and what is bulimia, and is it something that is mostly exclusive to...
Okay, well,
what is this?
What really distinguishes bulimia and anorexia nervosa are the presenting behaviors. Bulimics tend to eat, and they eat heartily. They often binge eat, and they don't gain weight. And it's interesting.
Wish that was me. How do you do that?
No, you don't want to use their techniques. You certainly don't want to use their techniques, because actually what they do is after they're eating, they're binge eating, then they're purging.
Oof.
They use laxatives, they use diuretics, and if you've ever been in the social company of a bulimic, you'll find that immediately after eating, she makes an excuse. She needs to go to the bathroom.
Right.
And therein lies the problem, because she eats and then she purges. For the bulimic, it is very relaxing, it is very tranquilizing to rid themselves of the food.
So you mentioned one way of getting rid of it, but we're also talking about vomiting.
Exactly.
And
exactly.
so they go to the bathroom, vomit up everything that's there, and then come back to the table saying, hello, everyone. Feeling good.
Yes. Feeling relaxed, feeling calm, feeling soothed.
Boy, oh boy, I wouldn't feel relaxed after that.
The interesting thing is, when I speak to bulimics in my practice, and I ask them, how is it for you after you purge, when you're done? And they say, to a woman, I feel calmer. I don't feel as irritated. I don't feel as stressed, as restless.
Wow.
Yeah.
Wow. So now, why is this, well, before we get to the next question, so we're discussing bulimics, which is something I see in the dental office because the acid
Sure.
will come up, that hydrochloric acid. Boy, will that'll be like Schwarzkopf through a rack. It'll just go right through the teeth.
Rots the teeth out.
And it's interesting because you see it mostly on the gum line.
Mm-hmm.
And it almost looks like something I call baker's decay, because they pick and the sugar settles on the gum, and the bakers don't clean their mouths while they're working, and they wind up getting decay like a ring around the tooth.
Now, isn't that interesting?
Yeah, and so you see the same thing with bulimics. What about anorexics?
Well, anorexics are different. Their weight tends to be about 20% less than what would be normal for their body structure. They eat little. Okay, starvation is more characteristic of the anorexic versus the bulimic who eats heartily. They exercise fanatically. They
Both or one? Who exercises?
The anorexic
Exercises fanatically.
Yes, yes. And the primary anorexic purges, like the bulimic.
Really?
But the bulimic girl does not starve herself. In atypical anorexia, you have the starvation, you have the hyperactivity and exercise, but you do not have the purging.
Like famous ones,
Karen Carpenter.
What a shame.
Oh.
I loved her voice so much.
It's a tragedy.
Oh,
it's a tragedy.
Unbelievable.
But actually, that was a tragedy, and every young person who grapples with this disorder is in a tragic place in their lives.
Let's go to the next concept and of discussion, and that is, does it seem to be exclusively for girls? Notice I didn't say women. Am I wrong? Am I right?
No,
or
no.
Why?
You're not wrong at all.
Why?
About 1% of our American teens suffer from this disorder.
1%?
1%.
It's huge.
If you think about it, in a class of 500 students, on the average, you'll find 5 students wrestling with this. Most people tend to think that anorexia is characterized by a female, or characterizes a female population. That's really not so. There are males also who are wrestling with this. In different studies, the ratios go from about 5-to-1 females to males to 8-to-1 females to males who suffer from this. The difference between the men and the women, or the boys and the girls actually, because they tend to be teenagers, is that the males are more focused on their athletic appearance and their athletic success rather than looking thin. Whereas with the girls, no matter how thin they get, they're thin enough.
There's so much to ask you. My gosh. First, are we still talking, I'm under the impression you're talking about anorexics at this moment.
At this moment.
What about bulimics?
Correct.
But meaning, is that exclusively for girls?
Bulimia is actually in many ways a form of anorexia. You have the involvement with food. With bulimics, you have the purging, but you don't have the starvation.
Right.
With anorexics, you have the starvation.
Right.
And purging or not.
So when we're having our discussion today, are you just putting everyone in one category,
I'm putting
basically?
them in one category.
And we're calling that category what?
Anorexia.
Okay, fine. Now,
Unless I
now
distinguish
understand.
it, yes.
Okay, so now I understand that. I've just never heard, nor have I seen, a boy doing this. You do, obviously.
You don't see it often, but yes, one does.
You do.
Not as often. When you think about it, 5-to-1 and 8-to-1 girls to boys.
Right.
They're there. They're not as prevalent. The numbers aren't as high, and they're also not as visible.
Is this something that is caused by our society? Is this something caused by our culture, or is somebody born into becoming an anorexic? How does this come on? What should a parent look for in the telltale signs? My child, is he or she becoming, anorexic?
Okay. When you have a girl, for example, that is bulimic, you'll find her not especially involved in exercise, but eating a lot. She eats a good deal, often binge eats, but she doesn't gain weight. For most of us, even for the kids, if they're eating a lot and binge eating, eventually they're going to put weight on.
Sure.
If you find them going to the bathroom, oftentimes right after a meal, you need to question it. If they're taking laxatives, something is going on. Or diuretics, something is happening. Most people do not eat like this. Most people do not take laxatives and diuretics.
No, of course not.
Right?
I think back years ago, the Rubenesque, the woman who was voluptuous, who, look what I'm doing with my hands, voluptuous, okay, and a full-figured gal. That was the way women looked, and they were enticingly beautiful.
Sure.
For centuries.
Well, it's interesting.
Why is it different today? Why does everybody want to look like Twiggy?
Well,
If you remember Twiggy.
I sure do. I sure do. If you look back, actually a colleague and friend of mine, Frederick Levinson, did some extensive research on anorexia nervosa and bulimia. And this is not a new term which we've coined in the 20th or 21st century.
No kidding.
The roots of it go back to the Renaissance days. Women were treated for TB and consumption. They were gaunt, they were thin, they were pale, they were sickly, at a time when the definition of beauty was in a voluptuous figure, was with some flesh, some meat on their bones.
Right.
And as the weight went up, so also did fertility. But one very inquisitive physician started following around some of these girls and noticed they were starving, they were hyperactive,
Really?
and in fact, their skin tone was suffering, the elasticity was suffering. They did not have
nutrition.
TB. No nutrition. Not TB, not consumption. So anorexia nervosa was first used hundreds of years ago.
Wow. You said during the Renaissance?
Yeah.
Italy, this was discovered? At what age would one begin to see these kind of changes? 7, 10, 12, 15?
Actually, pre-adolescence, as the young girls are going into puberty, so
Really?
12, 13 years of age through college.
Wow.
Yeah.
And is it due to peer pressure of looking a certain way? Is it trying to be an overachiever? I mean, what are some of the reasons why it's done?
Well, we on a superficial level, I wouldn't say we, but as a society, like to think that it's the girls having control over their lives and determining what goes into their body and looking skinny. By doing this, they really give up any secondary sexual characteristics. They become virtually genderless. So in a manner of speaking, the control is over what goes into their mouth. So if that's the control, I guess we can look at it from that perspective. But really, that's not the full picture. That's really not the full
Well,
picture.
does the full picture also bring into consideration the fashion industry?
Well,
Because let's, come on, go to school and say, look the way I'm dressed, and those people that are nice and trim, their clothing lays a certain way, and the fashion industry promotes a look.
absolutely.
Every year, the new look. I haven't seen Rubenesque come back yet.
It's not in vogue yet. It's not in vogue yet.
Right.
Well, we like to blame the fashion industry for what's going on with anorexia and bulimia because they have put into an icon this eating disorder. This is a very serious emotional problem. This is not something superficial. And we do ourselves and the girls an injustice by attempting to put it into that category. And I say the girls in this regard because the fashion industry is more closely connected to women and fashion.
Sure.
While the men are moving forward in this regard, not necessarily in a good way.
So, as far as I'm understanding this now, it's really an issue that is an emotional disturbance of sorts, and there is an underlying issue.
Yes.
What is it that you look for that underlying issue? Does it have something to do with, I hate my mother, I love my father, or I was emotionally told, beaten up as a child and told you're no good for nothing? I mean, what is this?
What's happening?
Yeah.
The ideological factors look to take the blame off of parents to get them off the hook. And people feel more comfortable putting the blame and the responsibility on the fashion industry.
Well, it's easy.
It's easier. It's easier because you can look to the designers, you can look to the young models, you can look to the industry itself. But what it does is minimize the severity of what this is about. What the fashion industry does is embody the icons of this emotional disturbance in the images of these young girls who are gaunt, sickly, very, very, very thin. But that's not what it's about.
So how much would you say the relationship with the mother and the daughter, and at what time, could affect what's going on?
All right. Well, back to Fred Levinson.
The way you said, all right, indicates now we're going to really open the door into an intimate discussion on this.
Yes, the interesting thing is that nobody's looking to place blame, but the reality is we need to go and look at the roots of what's bringing this particular problem about.
Yeah.
And when Fred Levinson did his research, what he was looking at and what he saw was the fact that the bedrock of what's happening here lies in the consistency of the delivery of food to the baby by the mother when she herself was irritated. And you may wonder, what does it mean? What does that mean?
Irritated. Does it mean somebody stepped on her foot? Maybe explain.
Good question.
What are we talking about?
Good question. You know when you're feeling stressed on the inside and you can't get away from it?
No, that's never happened to me in my entire life.
I'll use the generic you.
Of course. Go ahead.
It's that kind of feeling where people will say, I don't feel right. I feel off. I feel not afraid, but nervous. It doesn't go away.
Yeah.
When the mom is irritated in that manner and she's feeding her baby.
Like a newborn you're talking about?
I'm talking about a newborn now. What goes into the alimentary canal, what goes into the mouth, what goes into the digestive system, that which is all connected with food and the processing of food in the newborn baby's physiology, if that is paired with or combined with an irritated mom, then food is irritating. Food is irritating, and anything that goes into the body then is going to be irritated.
Really? So the baby just picks up on that and knows the feeling?
Well, it knows the feeling.
It doesn't say, aha, she's irritated right now.
It's all pre-verbal.
Right.
That's right. There are no words to express that.
Right. You don't need it. You don't need it. That's fascinating.
Isn't it fascinating?
How do we know this?
We know this by talking with the girls, examining them, looking at their behaviors, and extrapolating, and then also getting knowledge about that maternal child, and we infer the maternal-infant relationship. Because irritation is not something that you can quantify. It's something very, very subtle, but that you see the effects of or the symptomatology of.
That's fascinating. That's going to open up a whole door of discussion, which I do want to have in a second, but not without leaving this. Is there a difference between the mother offering the child breast or formula, or that's not relevant? What's relevant is just how the mother feels at the moment?
What's going on with the mother on a deep level, regardless if it's the breast or a bottle.
So in other words, if the mother's holding the baby and she's feeding the child with a formula and in a bottle, the baby's going to, I like the term in the book Stranger in a Strange Land by Robert Heinlein, baby's going to grok. The baby's going to just soak in what's happening just through the mother's body language. That's what you're telling me.
Yes, I'd like to just take that a step further. We know that the bonding begins between mom and baby at the moment of known conception. So we have 10 months of pregnancy where the baby is connecting more and more to the mom and vice versa. When the child is in the mom's arms being fed at the breast or from the bottle, he or she is at home base. That new mom is a microcosm for the entire universe for the baby.
Right.
So she's the base for security, for conflict, for predictability.
Survival.
And the baby in time will extrapolate on an unconscious level about the security, safety, and predictability in the world based on its experiences therein. If the mom is irritated, as I described a few minutes ago, the babies, our neonates, are like sponges or rosebuds. They soak everything up. They don't differentiate or distinguish between what's good or not good, what's happy or sad.
No discrimination, just take in.
Just take in. And the feelings are not happy or sad. They're calm and soothed or irritated or somewhere along that continuum.
What happens if you happen to have a male who, mother gives birth, the worst, mother dies, and now the male is the worst. The mother dies, and now you have a male. You have a father who's now taking the baby, and is it the exact same thing? Is there a difference there?
Well, we're going to talk when you have a mother that dies. You've got what is called an aberration, an interruption in the bonding. To the extent to which the father can connect with his baby, can feel some of those maternal feelings of being overwhelmed, of being connected, of being one with the baby is in a better place than not.
I see. But it's still not the same.
It's not the same. It's not the same. That's why when I'm working with new parents, I always say to them, if you have a colicky baby, It's not unhappy, it's not sad, it's not angry, it's just hyper irritated. And I say, we need to just carry the baby around. 6-7 hours a day, pop him in a snuggly. And my words are, and the poor moms look at me like, 6-7 hours a day? I said, you can give it to someone else. Grandma, Nana, Grandpa, neighbor, friend, so long as he or she is calm and soothed.
I'm chuckling to myself because the only phrase that's in my head right now is what I'm about to discuss with you is Jewish guilt. Because, I mean, it can be Catholic, it can be anything you want, but I just, as Jewish, I'm thinking Jewish guilt, and I could just see this now. How many mothers are going to be watching this? And they're going to say, my God, my kids are bulimic because of me. When I gave her milk, I just wasn't in a good frame of mind. I was upset.
Yes.
I was very, very, very interesting.
Yes.
Very interesting.
But this is not really about placing blame, because the fact of the matter is that no mom, no dad sets out to hurt their children.
Oh, of course not.
Nobody. But we do not have a mom-baby, a neonate mom-friendly environment.
Mm.
We have a situation now in our society where our lifestyles have changed, where there isn't support for the mom and the new baby, and they need that support. It's our most important, most precious investment, is supporting the neonate and the new mother. Our extended families, to a large extent, are available. So everybody is contributing, and thus, on a societal level, we have an increase in incidence of anorexia and bulimia.
So to take this further, am I correct in stating that it really comes down to, from what you're describing, that the neonate is at that moment when there is an irritation going on with the mother, excuse me, the concept and the feeling of security, of support, is lost. The feeling of it is lost, and it's replaced with something that's irritating. And that feeling, if it's on a large enough if it's constant, if it's repetitive,
It's continuity.
then the child begins to have that feeling within them.
Mm-hmm.
And that feeling within them gets manifested in, is this just one of the ways that feeling gets manifested, or other kind of conditions can come from this as well?
Well, when the child takes in the food, food is irritating. So the child is conditioned, or the neonate is conditioned to be irritated.
It's like Pavlov's dog.
And so you have
Eat
the
the food and be
pairing.
irritated.
It's the operant conditioning, old-fashioned
wow.
operant conditioning. You have the pairing of irritation with food.
Wow, that's fascinating.
Yes.
It's interesting.
Yes.
Then I guess my mom must have been fantastically happy when she was feeding me, because I eat.
You'd love to eat, right?
I love it. I don't have a problem with that. Unbelievable. If I excuse myself from the table, it's to see on the menu or on the glass case what's for dessert.
What's the next course? Huh?
Absolutely. To me, one dish is nothing more than an appetizer for the next. But very interesting, very fascinating. When you, I'm assuming, that you describe the dynamics of this to your patients. I don't know if you call them clients or patients. To me, they're patients. So do you describe what you've described to me to your patients to give them an epiphany, an understanding? Or it really doesn't matter because the feeling is so strong?
That's a really good question. I think the information is important. But if you look at our world, we probably have about 98% of the information that we need to solve the problems of the world. What we don't have is a level of emotional maturity to take it, internalize it, and use it constructively. So when I'm working with these women, for the most part, as I said before, they're women, what I do is just let them talk with me, and I ask them questions about their thoughts, their feelings, and their reactions internally to food and food kinds of situations. But more often than not, we work with the food tangentially. And it's addressed in a more secondary level, unless, of course, we've got a severe situation.
Right.
So, for example, if I have someone who is has lost a tremendous amount of weight, what I want to do right then and there is stop the weight loss.
Right.
But I tell them, I don't want you to gain more than 5 pounds or lose more than 5 pounds. We need to stay in this range.
Right.
Okay?
Right.
And then we're going to talk about how they feel when they've gained, how they feel when they've lost, what it means to them.
Fascinating. We're almost out of time. We have about 4 minutes left. It's amazing how quickly it goes.
Time flies.
Quick question. Yeah. When an anorexic girl looks in the mirror, what does she see?
Unfortunately, when an anorexic girl looks in the mirror, she is usually gaunt, objectively speaking, almost emaciated and wasting away looking.
She
sees a huge person who's grossly overweight. If you were to take an anorexic girl and ask her to hold her arm up and ask some of her friends to hold their arms up parallel to the ground, their arms would be 2 to 3 times larger than their anorexic friends.
In their mind. Oh, no, they're real people over the anorexic.
Yes.
But will the anorexic see that?
No. She's going to see a fat woman or fat girl.
Oh, my God.
Yes.
Now, is there a difference between what the bulimic sees, or it's the same thing?
The dynamics are what's different. The bulimic still sees someone who's overweight, but remember, she doesn't starve herself. She's purging, binge eating, not exercising as much, but still sees someone who's very overweight.
Well, in the 3 minutes or so that we have left, I want you to kind of wrap up. Right now, I know that you're looking and you're listening to this and you want to know, so what do we do? I'll tell her. So what do we do? I mean, now the parent looks and sees the child and goes, I think I got a problem. What do you do next?
Okay. We need to remember this is not a fashion issue. This is not a superficial issue. This is delusional and hallucinatory thinking. I mean, technically speaking, it's body image dysmorphia.
So you can't go over to your child and say, now look,
Stop
I
it.
know you're doing this, now cut it out.
Yes.
Won't work.
Won't work.
Okay.
Because the dysmorphia has to do with a body that is normal and someone sees it grossly overweight, grossly flawed. So what do? There are lots of programs out there. Everyone, I would say, to the person, wants to help these girls. Wants to help these girls.
So seek professional care first.
Absolutely.
Don't think you can do this on your own, because it's not going to work.
And don't listen to your daughters who say, this is fine, there's no problem, stop making something of it. I look good. I just want to be slender. Don't listen. Our children are not our friends, nor should they be.
Yeah, right.
Our children, our responsibilities to parent, they don't have rights and privileges that they're entitled to. We have to bring them up. If they had a broken arm or a leg, or they had their front teeth knocked out, you would take them to the dentist, you would take them to the orthopedist. And this is a serious, serious problem.
So the first thing one would do, because they would say, well, what do I look for? What do I do? The average person then should probably contact their physician, their internist or their pediatrician, and say, do you know the name of someone who can treat this condition? I'm suspect that this is what's going on. Because you need direction. You know the yellow pages.
Absolutely not.
You understand.
Absolutely not.
You need direction.
And another way or another approach to that is, if you know other parents whose children may be grappling with this issue, find out the names of people, professionals, who have worked with those whom you know, whom you trust, and who've had good results, and interview them. And one rule of thumb, in addition to what I've just told you, is I always say to prospective patients, when you're going to work with a practitioner, I don't care if it's a psychologist, psychiatrist, mental health counselor, not only interview them, you need to find out if he or she has been on the other side of the desk. Have they experienced their own long-term individual therapy?
Great advice. We're out of time.
It's been a pleasure.
Dr. Maryann Schaefer, thank you so much. Will you come back again with other bits of information?
I'd be delighted.
Excellent. You're a delight. I learned a lot from you today. That's the best compliment I can give you.
Thank you. Good to be here.
Thanks. And it's good to be here with you. I hope you learned something, and if you know someone with this condition, you have some insight, you have a little bit of an epiphany, and see what you can do to help them. So, Dr. Harvey Passes saying, whatever you do, just like Dr. Schaefer, do it with passion. See you again next time.
Thank you.